Okay, good afternoon, everyone, and welcome to this week's Webinar Wednesday, an intimate look at sexual healing after cancer. And this webinar is in recognition of Gynecologic Cancer Awareness Month, which is the month of September. Just a few reminders for our Zoom participants. Please mute your microphones when not speaking. Remember, we are streaming this to Facebook Live, and we will be uploading this to our YouTube library later. Please use the chat box to ask questions if questions come up during the presentation, although we'll have some time for Q&A at the end as well. And if you are joining us on Facebook Live, please use the comments section to ask questions. The Webinar Wednesday series is a program by the University of Chicago Comprehensive Cancer Center Office of Community Engagement and Cancer Health Equity. My name is Aaliyah Poulos, and I'm an education outreach specialist in this office, and we are thrilled to bring our faculty expertise to the greater UChicago community and beyond. Today's speaker is Dr. Amy Siston. She is an assistant professor of psycho-oncology at the University of Chicago Medicine. And I'm going to stop sharing my screen and throw it to Dr. Siston.
Thanks, Aaliyah. I'm going to try to share my screen, and we can go ahead and get started. Give me a second. And I'm very sorry. That will be my daughter. Sorry about that. She's not going to be very pleased to know that she just went live. So sorry about that. That's the benefits from working at home. You never know what's going to pop up here. Thank you, Aaliyah, for inviting me to speak this afternoon at the webinar. This is one of my favorite topics to talk about. As Aaliyah has said, I'm a clinical psychologist. I'm also a certified sex therapist with specialties in psycho-oncology and sexual health. So today I will be talking with you about sexual healing after cancer, an intimate look, as Aaliyah has mentioned. The objectives of the webinar this afternoon are to provide a bit of a discussion of the prevalence of sexual issues following cancer treatment, the different types of sexual issues that patients present with, the barriers to getting help, what sex therapy treatment involves or what that looks like, and a little bit about the program at the University of Chicago. In terms of sexual function and what we know is that 40 to 100% of survivors experience sexual difficulties during or following cancer treatment. That 40 to 80% of young survivors report distressing sexual side effects, and that 50% of young survivors report problems in 2 or more areas of sexual function, and that the majority of survivors do not receive support for sexual problems in the context of their cancer. The common sexual issues reported are that of low desire or low libido, with 25 to 59% of individuals reporting these issues. 24 to 60% report issues of sexual arousal issues, difficulty with arousal, or difficulty getting or maintaining any type of lubrication. 27 to 38% report difficulties or problems with orgasm, and 29 to 40% report pain with intercourse or sexual penetration. What some of these problems look like in terms of sexual issues, just taking a little bit of a closer look, the most common sexual problem is that of loss of sexual desire, which can result from a single or a combination of different factors. One of those issues are medical treatment effects, such as abrupt and early menopause, just feeling tired or lousy, and nausea from treatment. Body image. In terms of body image, almost all illnesses will impact body image, at least temporarily. Low sexual self-image is just that not feeling physically attractive, maybe due to things like hair loss, weight gain or weight loss, scarring, the loss of self-confidence in how you look or how you feel, and kind of that perceived accelerated aging. I have many women come in and tell me, I just feel so old, I look so old. Body image can impact a woman's ability to engage in to feel confident about, and to enjoy a healthy sex life. There's also emotional barriers of things like depression or feeling sad, anxiety or fear or worry. Both of these things can negatively impact our sexuality. Stress can also be a very large barrier. Stress associated not only with disease, but just general life issues. Another problem that women talk about is what's going on? Why is it taking so long? Why is it taking so long to feel lubricated? Why am I so dry? I feel like my body is like a desert. So medical treatment can lead to vaginal changes. It can take longer for the vagina to enlarge and get moist, leading to things like vaginal dryness and irritation. Low estrogen levels can also cause the lining of the vagina to get thinner and lose some of its ability to stretch, or what some refer to as be more elastic. This is what we call vaginal or vulvovaginal atrophy. There's changes in the vagina due to the low estrogen. In addition, there's also what was already mentioned, this insufficient lubrication, which can lead to very painful intercourse. A woman's orgasms may change over time. Aging, menopause, sometimes medication, any number of things can change or can affect the ability to orgasm, or what some refer to as climax. So not only medical treatment, like feeling tired or not feeling well, but also things like the medication that is used to treat things like depression or anxiety can interfere with one's normal ability to achieve an orgasm. How you feel about yourself, how I feel about myself, but also how I perceive my partner to feel about me can affect your ability to achieve an orgasm. What happens there, just like with stress or anxiety or any of these things, is you start thinking more about, what does my partner think? Does my partner notice that I feel anxious? Does my partner feel, or can my partner see the scars on my body? The more you start thinking about all of these things, the less focused that you are on your ability to enjoy that moment, to enjoy what it feels like to be together with your partner, and to be able to achieve climax or an orgasm. In addition to the information already presented on some of the common sexual issues, sex can also be very, very painful. And this is due to medical treatment, like scarring from treatment, things like radiation or surgery may change the shape of the vagina, vaginal dryness, the vaginal atrophy. All these things taken together can contribute to pain. There's also an emotional factor that gets in the way too, and that's the anxiety. If there's a painful experience with sex, of course, there's going to be anxiety. Is this going to happen again? And when you add on that layer of anxiety to pain that may already be there because of medical reasons, that just heightens the pain factor even more. So what happens next? I hope you guys can see this cycle here, this wheel here. What happens next when there's pain is, if you've had, it only takes one painful experience. What happens is the body and your mind starts to anticipate that maybe this is going to happen again. And what happens in response to that, the body kind of gets tight. And this is the vaginal muscles will get tight. And that tightening then becomes very painful if penetration is attempted. And sometimes penetration is completely just not even possible. Patients will come in and talk about, oh, my partner says it feels like they're hitting a wall or something. So it's that pain that gets very intense. The body starts reacting, kind of bracing for that pain, and you start getting anxious about it. And what do? You start avoiding intimacy. Like, I don't want to do that because that's going to cause a lot of pain. That right there in itself really takes the desire that may have been present for sex and it completely takes it out. Who would want to knowingly engage in something that they know hurts them. It's kind of hard to have desire for something like that where you know there's going to be pain involved. Within this cycle here, it's not only avoidance of intimacy, but it's avoidance of all kinds of intimacy. So it may be, oh, my partner is giving me a shoulder massage. Not sure if I want to do that, because if I let him or her do that, that may mean they want to be intimate, and I don't want to do that. So what happens is patients start becoming more and more avoidant of all kinds of intimacy. Simple things like holding hands, a shoulder rub, sitting next to each other on the sofa. They really start avoiding those things because they feel bad. If they don't want to engage in intercourse, they don't want to engage in intimacy, they feel bad for their partner that they're not able to do this. So they avoid all of this together. If left untreated, the sexual issues that I'm speaking of now really can interfere with quality of life. Untreated sexual issues may contribute to things like more anxiety, more depression or distress, and poor body image. Many studies find that cancer patients are unsatisfied already with how their bodies look, how their bodies feel. There are reports of women talking about their bodies feeling maimed, damaged, and are incomplete as a result of medical treatment. In fact, about 50 to 75% of survivors report problems with how they see their bodies. So what makes sexual side effects so unique compared to all the other side effects that one can experience? So the other treatment-related side effects, whether it be fatigue, whether that be nausea, whether that be pain, other treatment side effects generally will improve or will resolve with time. Sexual issues do not necessarily improve or resolve with time, but they can get better with treatment. If you leave sexual issues untreated, left alone, oh, maybe they'll just get better as time goes on, they in fact may worsen. So we really try not to do things like that. We know there's help available, and I'm going to talk to you about some of those methods. So why is sex so important then too in cancer care? Sex actually ranks consistently among the top 5 unmet needs of survivors. What gets in the way in terms of unmet needs is a host of issues that may interfere with sexual function. One of those things probably is when you first found out you were diagnosed with cancer, you probably were focused on what's the plan? How am I going to survive? How am I gonna live going forward? That was the main focus. In the early phases of treatment, sexual function probably was very low priority. Curing cancer becomes the main intent. But after a while, as things get better, as treatment is complete, other questions start to come up. You might be wondering kind of, how normal can this be? If my cancer is under control, how will this affect my sex life? When can I return to a normal sex life? Why am I having issues now? So this is kind of our don't ask, don't tell, which we do not do. Sexual health or sexual wellness becomes kind of the hot potato topic, not only for patients, but also for providers. For patients, it's kind of like, well, nobody asked me, so I'm not going to say anything. I don't want to burden my provider, he or she. I know they're so busy. This will get better. I'm just not going to ask them. Or maybe kind of feeling embarrassed or a little bit vulnerable or not knowing how to ask the question. So we just avoid it altogether. For providers, this is also a hot potato topic. Well, it's not our department, it's that other person's department. If the patients really had a problem or there really was something going on, they're probably going to ask us. Maybe they'll feel kind of offended if I ask. That may not be their priority right now. Maybe they're too old for this. This may not be something they're interested in, or they don't have a partner. So I'm not going to ask these questions. Or maybe even feeling a little bit embarrassed, him or herself too. So we don't want this to be the hot potato topic, and certainly why I'm talking to you about these things today, and I hope your providers are too. Another thing that gets in the way is kind of these unrealistic, what I call sex expectations. Treatment's over. I'm feeling better. I'm feeling good. Boom, this is what my partner does for me. I'm not quite there yet. I may look okay. You may see me as feeling okay, but I'm not quite there yet. So we have these unrealistic expectations of what should occur when somebody completes treatment. Things like anxiety can remain really high, and it is one of the most frequently reported and lasting psychological concerns. Illness does provoke distracting worries. Am I healthy enough to engage in sex? Am I healthy enough to perform? Will I hurt myself? Sexual encounters almost become a little bit of a test. Will it work this time? Will I have problems? Pain during sex can be a distraction. It creates more anxiety. It elicits fear about one's health. Benign or novel sensations that are experienced during sex can also set a chain reaction off for anxious thought. This is kind of what I felt before. Does this mean the cancer has come back? Depression in cancer is very common, certainly greater in cancer patients than the normal population or populations without cancer. Depression can lead to decreased quality of life. Fatigue can be a symptom of depression, can also get in the way of sexual health, changes in self-esteem, and certainly the medication that is used to treat depression can interfere with one's ability to feel desire and other sexual health issues. These medications are very good in terms of helping with mood, but I would encourage you, if sexual issues started, when you start to take something like an antidepressant, just talk with your doctors because there's alternative medications available. There is a lot of hope, and that's the good news. There's hope for all of these issues. Sex is often a way to experience intimacy, but intimacy is not necessarily about sex. Being intimate means being physically and emotionally close to someone else. Intimacy is about being loved, demonstrating mutual care and concern, showing you value another person and feeling valued in return. And intimacy can be expressed in many different ways. One of those ways to express intimacy, care, concern is to create it, to create intimacy, to create desire. It's what I refer to as the 3 T's. First T is to talk to your partner. Share any fears that you have about resuming sexual intimacy, but also allow your partner to share any fears that she or he has about returning to sexual intimacy. Some common things that partners talk about is, I don't want to hurt her. I have that image in my head of her being sick. I'm not sure if this is what she wants. Really, the best intimacy happens when partners can communicate their needs. So talking is really a great first step. The second T is taking it slow. It may be easier to start with non-sexual type of activities, little cuddles, maybe a little bit of a massage, rather than to put the focus on penetrative sex. If you take that layer of pressure off about that, take it slow, start reintroducing yourself to some non-intercourse related activities, it can make a wealth of difference. And the third T is just taking the time to plan ahead. Sex may need to be less spontaneous after treatment. Choosing a time when you feel you're not tired, when you're not uncomfortable, when you have a little time to build arousal is great. Taking the time to be maybe inventive or creative, exploring different types of sexual practices. Some of the sexual practices you used to use may not be possible because of how you're feeling. Intercourse may be difficult, but there's a wealth of different sex practices out there. There's a whole blueprint of pleasurable zones on our bodies. It's a great way really to explore with partner or with yourself. Whenever I say sex is not going to be spontaneous, I get this, oh no, what are you talking about? We have to circle it on a calendar, we have to plan. That doesn't feel very, very arousing. And I kind of have to give a little mini lecture on what I mean by that. So sex that is spontaneous is kind of that desire that comes out of nowhere. It's the type of desire that is seen in movies. It's usually experienced in the beginning of a relationship or after long absences, maybe from a partner. It's less likely to be seen in longer term relationships. The type of desire that is seen in long-term relationships is what we call responsive desire. And what that means is you may not feel initially sexual desire, but with some sufficient sexual stimuli, maybe the appropriate context, you can move kind of from this neutral state to feeling more arousal or desire. So I describe it as, think of more like a sparkler. It slowly builds, but it maintains a little bit of fire, but it needs a little time to build up versus kind of just the fire that spontaneously erupts. One of the other sexual issues is that of vaginal dryness or arousal. Going down a water slide without water, you understand what foreplay is, why it's so important. It's not just foreplay, but also the need to probably use a lubricant. If you're in menopause, went into abrupt menopause because of treatment, you've had your ovaries removed, you're going to need some lubricant that you buy over the counter to help make sex less painful, to help contribute to moisture to the vagina, so you're not going down a slide without water. Foreplay, taking the time to achieve satisfactory degree of stimulation before beginning intercourse is essential. Men and women differ in this completely. Most men can achieve arousal within a minute. Women in general, without cancer histories, will take 15 to 20 minutes. You can count on taking a little bit longer. And many women talk, oh, I need 30 minutes. I need a little bit more than that. I need a little bit less than that. The purpose here is not so much the minutes, but that you do need a little time. Sexual arousal, sexual desire, all begins up here in your brain. You have to be in the headspace of being able to enjoy the moment, not being distracted, and taking the time. So really allow yourself the time to experience that. During the lockdown of the pandemic, there's a lot of shows on Netflix that I've never seen before. One of them was Grace and Frankie, if anybody has ever seen this program. I thought, wow, they really do great discussion of the use of vibrators. So because the orgasm generally changes, it's a normal process in terms of aging, the ability to achieve an orgasm changes. What that means is the way you used to achieve an orgasm, or maybe if you had difficulty before, maybe feel a little bit more difficulty. What I used to do is no longer working. The use of something like changing the way the friction, the stimulation, varying that, using something like a vibrator, which can definitely help with this, is a great sex tech tool that can make a world of difference. The purpose of, kind of showing this little bit of here, Grace and Frankie, this is really normalizing this experience, that this is a normal part of aging, but also can occur because of cancer treatment, but we have great methods to use to treat them. Pain, okay? Many women, many patients present with painful sex, really quick kill of sexual desire or arousal. There's many factors that go into pain. Anxiety, as I spoke about, is, remember that little bit of that wheel there, that cycle. being able to communicate with your partner. The use of a lubricant is important. Avoiding things like deep thrusting or changing positions. And certainly when I hear somebody talking about pain, it's referrals to help understand why is your body doing this, and maybe to one of our pelvic floor physical therapists, maybe to one of our gynecologists that specialize in sexual medicine, to really better understand what's going on here, because we know there are methods to help. You don't have to be in pain. One of those methods as a sex therapist, one of those methods that we use is called Sensate Focus exercises. And Sensate Focus is meant to improve one's awareness of one's own needs and the needs of their partner. And what Sensate Focus is a series of very brief homework exercises. And I stress homework because I often get patients saying, are we doing this in the office? No, we're not doing any of this in the office. And we're not doing any of these exercises on the camera here. These are for you to do in the privacy of your own home. These exercises are very brief. They're practiced for maybe 15, 30 minutes. What the couple does is they agree not to engage in intercourse. And the focus is more on the heightened sensory awareness of touch, sight, sound, and smell. So as an example, each partner would begin by softly touching each other, clothed. Couples are instructed to enjoy the experience and what that sensation of touch feels like for them. In the next phase of the exercise, it may be, again, to do the same thing. Each partner softly touches the other, but this time they may choose to be unclothed. Partners communicate what they like, what they don't like. The focus again is on what does that touch mean for me? The idea with these exercises too is to help you stay present, to help you stay in the moment, to help you focus on what's happening between you and your partner and what it feels like for your body, not to focus on the laundry I need to do, what I need to make for dinner, what's on my schedule for work tomorrow, how do I feel? How do I look? But to really focus on what it feels in this moment. These exercises have been used since the 1950s and are very successful and something that we still use today. There's some discussion of low sexual image or body image earlier in the presentation. So I wanted to reiterate that these feelings are very normal, that body image is impacted by cancer and its treatment, but body image is also part of a larger cultural issue, and especially for women. Women have cultural permission to criticize ourselves, but we are punished if we praise ourselves. There are probably very few women that stand up in front of the mirror and say, wow, I really like what I see. So one of the things we focus on in therapy too is replacing some of that self-criticism with self-kindness or self-compassion. Getting help. Okay, lots in the news today and recently, how to talk to your doctor when you have cancer, or how do you talk to your doctor about sex when you have cancer, how to get back to being intimate after cancer, questions to ask your doctor about sex and cancer. And I circled the last one here in red. Woman Lab is what is part of the program of PRISM. It's the website with a wealth of information for knowledge and resource for every woman, information about sex after cancer, about menopause, and so much more. You'll be able to learn about what a sex therapist does, what a pelvic floor physical therapist does, information about lubricants, information about where to find some of these programs. You can follow the Women Lab program on Twitter or Facebook. Women Lab is the website that came out of the PRISM program at University of Chicago. And this is the program in integrative sexual medicine for women and girls who've gone through cancer. The number is on the screen for making an appointment. The appointments are by video now. And all patients should be current in their gynecology before coming to PRISM, including if there's been a pelvic exam or a pap smear, if these things are indicated. So this program and the specialty in emphasizing sexual health and cancer is one of few across the United States. I believe we're 1 in 6 that offer something like this. So it's a real value. I really would encourage you to visit the program or definitely the website for more information. And just to explain a little bit more about what a sex therapist does, because I do get these questions often. So sex therapy is a range of therapeutic process which may be used to initiate, restore, and to enrich both the sexuality and the sexual components of intimate relationships. The goal of sex therapy is to help integrate new medical interventions into sexual routine. We use things like psychosexual education, communication about what the sexual concerns are, different behavioral interventions and cognitive interventions. I meet with patients alone. Sometimes I meet with patients and their partners too. And if you wanted to go outside of the University of Chicago system and look for a sex therapist that maybe specializes in something else besides cancer, I would encourage you to go to ASECT, which is the American Association of Sex Educator, Counselor, and Therapists website. And there you'll find credentials and or couples therapists, either who have experience in various sexual health issues or cancer like myself. And kind of the take-home notes here before we wrap it up this afternoon. Few things I wanted to stress is that sexuality is part of every person from before they were born until they die. Sexuality is a quality of life issue. Each person has the right to their sexuality, but that emotional wellness is very important too. So with that, I thank you, and I'm very happy to take any questions. So I will stop my share here. Yeah. Okay.
Thank you so much, Dr.
You're
Siston.
welcome.
This is, as I mentioned earlier, this is a topic that we don't talk about enough. We certainly don't on our webinars. This is very different for us. So thank you so much for sharing your expertise here. So this is the kind of thing that I imagine if people have questions, they'll probably prefer to use the chat function. And I certainly would not, if someone wants to send a question directly to me, in the interest of discretion, I certainly would not, reveal who asked the question. But I had a couple of questions here. One of them came in through the chat, and some other ones were some ones that I had come up with. So my first question, I guess, if a cancer patient is experiencing some sort of sexual dysfunction or dissatisfaction, I should say, following their treatment, what is their first step? Should they tell their doctor? Should they seek out a sex therapist on their own? Like, what would you advise is the first step there?
So I think the first step is to let your doctor know, and talk with them and see what recommendations they provide. You will see throughout the hospital in many of the different cancer clinics the information for PRISM, the program for women and girls who've gone through cancer treatment. Definitely would encourage you to contact them or go to Women Lab. If you're looking for someone outside of the U of C system, then you'd be looking for probably a sex therapist to talk with you about some of your concerns.
And are there a lot of sex therapists that focus on therapy after cancer or for cancer patients, or is that more housed within some of the hospital systems?
So there are some, there's not a lot, definitely more housed within some of the hospital systems, but some in private practice too. In terms of locally, probably few, but they are available.
Do you see similar issues, sexual issues in men following cancer diagnosis?
Absolutely. I'm really glad you said that. I don't want to leave out men, but very, very similar issues with men. Many reported sexual issues, just like what women report. Same type of barriers in terms of talking with your provider, I'm not comfortable, or issues within their partnered relationship because of. Certainly with men, the component that's a little bit different is medications to treat the sexual issues in men, like Viagra, Cialis, there's commercials on all of these things. These things are available, not to help with the desire, but to help produce things like an erection for satisfactory sexual encounters. For women, there are some medications available, but we're new to this. The medications are available are new. The results that we see in men from the medication are different for women. Again, it's new. It's a really good start, but these are not take this pill and you're going to get 100% satisfaction. We're just not there yet.
Is there any kind of hormonal therapy that is used to relieve some of these issues, or is it maybe too much of an interference, perhaps with some cancer treatments?
Yeah, Aaliyah, that's a great question. There are hormonal methods to help with some of these issues. These are the questions that you need to talk with your oncologist about or your gynecologist about, because many of the providers don't want you using any type of hormonal treatments, especially if you've had a cancer that's hormonal related. So it's a great question to ask your providers.
And then could you just sort of walk us through, when someone, whether it's an individual or a couple, walks into a sex therapist's office, what's the rundown? What happens in that sort of space? I think a lot of us probably are not necessarily familiar with how those appointments would probably go.
Yeah. Great question. So it really looks like a regular psychology evaluation. So what happens is we do what's called an evaluation. So we ask lots of questions about your cancer, how you're coping with your cancer, how you're feeling in terms of your emotions. And then we ask about your sexual health. And that's going to include questions about if you have any issues, when it started, what does that look like? Do you feel desire? Are you having issues with arousal? Are you having issues with painful sex? What have you tried? What has worked? What hasn't worked? Are you on any medications? What's your relationship look like? Are there any issues in your relationship? How does your partner treat these problems, when they occur? How do you deal with them? How do you deal with them together? So really, it's a lot of talking. Once we get into treatment, it's a lot of communicating, problem solving, working sometimes to reframe some of those thoughts that individuals have, changing behaviors. And the exercises like Sensate Focus exercises or others like that, these are things we talk about in session, and then we ask you to go ahead and try at home. And then you'll come back and tell us how things went, and we'll continue to talk and work on problems like that.
Sounds like sort of a mix between almost like a physical therapist and a therapist that you'd see for your mental health, right? Sort of.
Yes. So it's a combination of those two things, because patients will come and say, well, I have a therapist that's helping me with the anxiety, but I just want you to help me with the pain. And there's so much overlap, because it's very hard to tease out and say, well, your problem is only pain, because we know there's anxiety related to that. We know there may be some relationship issues related to that, maybe new or old. And we know there's, other stressors that can be related to that too. So it's hard to tease out and say, you see this specialist for this and this specialist for that. Really, there's so much overlap. And often we may not be starting with the sexual issue first. We may need to address the more pertinent issue of anxiety and how that's interfering. And this is not a hurry up and let's get this over with. This is a process that will continue to get better over time with therapy and with some of the other providers that we work with too. Again, I work closely with pelvic floor physical therapists, with gynecologists from our PRISM program, and other providers too.
This is just sort of a good reminder, as with all our cancer focused speakers, that pretty much every cancer related issue, all these issues are interrelated with other aspects of your physical and mental health, and this certainly seems no different.
Yeah. Yeah. We don't want this to be a problem that's overlooked. We don't want this to be a problem that's forgotten about. There's many losses with cancer. There's a loss, if it's of a work role, a loss of what your role is at home, maybe as a parent or a partner, a loss of, things like physically, my hair, a body part, all these losses along the way. Sex becomes a loss too, but it becomes a loss that you don't necessarily have to grieve for, that you can achieve. Maybe it doesn't look the same way, but maybe it can feel very similar.
Yeah, the loss piece is real. I was speaking with a cancer survivor who had a double mastectomy and a hysterectomy, and she goes, I'm a shell of a woman, that's difficult to come back from.
Yeah, yeah, yeah. This feeling of my body has been changed. My body has been scarred. I don't know what to feel. I don't know how to feel again, how to feel those feelings again. I feel, those parts of my body are shut off, and they
Right,
don't
right.
have to be.
Could you explain, I know you're not a pelvic floor therapist, but just for those who may be a little bit unfamiliar with what a pelvic floor therapist does, could you explain a little bit about pelvic floor therapy and a therapist's role in that?
Sure, I can try. I won't do it as well as they will. And again, on Woman Lab, there is a video of a couple of our pelvic floor therapists explaining specifically what they do. But pelvic floor physical therapists will really look at the area of the pelvis region. There's many, and I don't know how many muscles are involved there, but help the patient to understand where the issues of discomfort are, why they're having these issues. It may involve some external massage, some internal massage. They certainly focus a lot on breathing exercises, helping a person to feel relaxed, helping a person to understand what it means when their body feels tight and tense versus their body, things like their vagina being more relaxed and less tense. I know I didn't do as good a job as they do, so
No,
excuse me. Go to Woman Lab.
that's a good overview. Actually, would you mind at some point just putting the link to Woman Lab in the chat box here
Sure,
in Zoom? I think this just sounds like a really great
sure.
community resource for
Yeah.
anyone who is experiencing these issues. So I'm going to go ahead and just check our Facebook Live to make sure that we don't have any questions coming in there. And for our Zoom participants, if you have any questions for Dr. Siston, feel free to unmute yourself or use the chat box. Just check here. Okay, I don't see any other questions. So once again, Dr.
This is a
Siston.
shy group.
This
is a shy group. Usually I get a few questions, don't worry if you feel like this is embarrassing, type it in or send it to Leah. Usually there's a few questions, again, sexual health is very normal. Had to have issues at some point, is very common. We just, want to let you know, again, there's hope and methods to help. Questions I will take certainly off camera too. That's fine as well.
Yeah. I was just going to suggest that we're going to go ahead and end our Facebook Live here. Thank you to all of us who joined us on Facebook Live today. And thank you again to Dr. Siston for speaking about sexual health after cancer.
Thank you.